Anyway, welcome to Questioning Assumptions and Improving Care for Marginalized Communities, and I will let the discussion get going.
Alrighty. So hi. So I'm Sarah Haig. I'm generally the mistress of ceremonies for the San Diego Pain Summit, but I'm also PT in Chicago, and lucky enough, the same place as I guess our star for the evening. I did this because that's where you are on my computer, but that's probably not the case for everyone. So I'd love to start out by introducing Dr. Devra Sheldon. So I've had I don't even know how many years we've known each other now, Devra, but just anytime.
I can't count with COVID. I don't know how many anything is now that COVID's happened. I'm like, I don't know how many that is now.
No idea. But I will tell you that with Devra, it seems like I've known her forever, even when we haven't seen each other in forever. And she always has a lot of brilliant things to say. So Devra has just completed her transitional doctorate of physical therapy, and her final project was on like shame and stigma. And I did not have the whole title of her final project. But so tonight we're going to be talking about some of the things that came from the discussion of the talk in the online San Diego Pain Summit. So Devra, how should we start? Is there anything that you want to start with right now?
I'm going to give a little 2-second kind of background of me, so people aren't like, who is this white lady talking about this thing? So I work in marginalized communities for the last 15 plus years. I've been on the west side of Chicago, primarily Medicaid and uninsured population. And I love it. I love my patients. I love the community I serve. Clearly it was, who I was meant to serve. Not that I don't love all my patients from all backgrounds, but it is really just been a deep connection for me and the work that I do there. And people have all sorts of things they say to me when they hear that I work where I work. And, oh, don't you want to work with athletes, or why do you want to work there? I'm like, because I love it and they deserve quality care. And right, like this is so, and then, I'll hear things like, well, don't you want to work with people who are motivated? I'm like, what? So, right. Like what makes you think my patients are motivated? So it, and certainly with the persistent pain population, they experience so much shame and stigma related to their pain care. So it really kind of transitions, during the Q&A to these, conversations, which is why we're here today chatting about it.
Okay. So, like you just explained beautifully, who are you and why this white woman up here talking about anything like this?
Right.
So when we're working with people who are different than ourselves, one of the things, and like the questions that came in, one of the things people kept talking about was like this connectedness. So like how do we make connections with people who are so different from maybe our own background, and especially when that's a person who's in a situation where, like you just said, like they're perceived as unmotivated, they haven't had the best care maybe because of those perceptions. So how do you make that connection?
So I always recognize that my set of experiences is not another person's set of experiences. And, when you serve a community for a long time, you certainly start to learn a lot more deeply, some of the common experiences that people from the community you serve might have. But one of the barriers that come in with that cultural difference is that we then come with different expectations, right? And different beliefs. Patients come to us with their whole life telling them that a pill is going to fix it, that, right, the medical model. And now they've come to this therapist that their pain doctor wants them to go see. And they're like, what you got for me? Right. And certainly within a marginalized community and in a, chronic pain population, you can pretty much guarantee that not everybody, but there'll be a large proportion who may have experienced some iatrogenic harm from their medical encounters, right? You might encounter deep feelings of injustice, about care denial, about not feeling heard, not being believed. not having their experiences acknowledged. And that sense of rejection is really harmful. It feels socially isolating. It's angering, and so just being open and knowing that that's a real possibility of something that could be expressed to me, or just they've never experienced a medical dynamic where somebody was so reflective back to ensure that they understood their narrative well. I have the habit of when someone is giving me history and my subjective, I literally read back to them what I wrote so that they can correct it. They can ensure that I've really understood what they were saying. And I say that, I want to make sure I got it right. I've had a lot of patients impart really unpleasant stories about feeling like practitioners lied in medical notes about them or made assumptions about them that they then read in their medical notes later. So I am always extremely open and honest and very clear that people literally know what I'm typing. Like I will type it and read it back even during daily notes, right? Even if they just come in for a visit and they tell me, I'll go, okay, so what I'm hearing is X, Y, or Z. And they have the opportunity to correct it or, change it or say, yes, that's right, you've got it. And then I actually use their narratives self-referentially. So if I'm suggesting some exercise or some option for a change of movement or something, I will reference their narrative first. I might say, I know you imparted that mornings are really difficult for you. What do you think about this? But it helps them know that I truly heard their concern and I'm specifically targeting that concern, even if it sounds really small, right? I really drill down to minutia over the course of care, right? Every session is about learning more deeply the salience and valence of the different aspects and components of their lived experience and how my physical therapy can fit into that and make it better for them. And I certainly have moments of frustration, right? I have a patient right now who has very inflexible rules of engagement. And that's not uncommon, right? We all bring our experiences that bring our individual rules of engagement. There's patients you can say, here's your home exercises, try to do them a couple times a day. And they're like, I did them 4 times a day, right? We all have those like overachievers who really want to perform well for us. And, there's other people that are like, listen, I can't move before noon, right? So me telling them they need to do their back extensions, 10 times a day, it doesn't fit. And this particular individual just this week, it's taken 4 or 5 sessions to find, even though we've talked about it's possible this exercise that feels really good in clinic might help you move through that really painful morning stage, right? That protracted time that you're unable to do anything functional or valuable that you're interested in doing. And every way we've tried to fit it, it's just, no, I can't do that. No, that doesn't work. And it would be really easy for me to say this patient doesn't want to get better, right? That's a real simple thing that I could say. But the bottom line is her entirety of her life experience, her lived experience as somebody who hurts, has brought her to this moment where that is how she manages and feels more comfortable. And I can't just reject it. Right? I can't just say, well, if you're really interested in getting better, then you're going to do this thing that's miserable and every other experience has told you, not to do. And it took about 4 or 5 sessions to find a thing she could do. And Tuesday we figured out she can lay on her belly before getting out of bed. We'll offset the hips a little bit, right? I mean, and I have a student right now and, we talked about, she's got some inflexible, this is who she is. This is where she's at. And it's my job to keep working to make it fit better. She's probably used to people dismissing her and being like, well, that won't work, and leaving it at that and not really working with her to understand more deeply. That came up in quite a few of the questions people posed. And what was interesting was our expectations as practitioners, right? All of us in our training are built up, right? We're really like, you are an expert at what you're learning, right? You're the professional who does this thing. And we all leave our training feeling really good and confident about our skills and the experts in that thing that all of our, professors told us we were now experts in. But it's not the same as, being the expert in what it's like to be discriminated against, right? It's not the same as being an expert and feeling like your practitioner or the ER doctor or nurse or whomever is making a joke out of your complaints and doesn't believe your pain. And it's really, and that thing that I might find as a barrier to their care might be a really important piece of culture and identity for them, right? It might be the thing that ties them to their social groups. It might be a thing that ties them to their cultural identity. I mean, I have patients that come in and tell me all sorts of interesting self-treatments. I remember early in my time at my hospital, I haven't heard it a lot recently, but oh yeah, I like using orange alcohol and I rub it on my knee, or green alcohol. So we got green alcohol and orange alcohol. And really, so I'm like, well, let's look this up. I don't know anything about that. And it's rubbing alcohol with some dye. And I think one has menthol in it, one is, right. And you they buy it at Family Dollar or whatever. And, it's like for arthritis, for this, whatever. And I don't need to poo-poo it, right? I don't need to be like, well, that's absurd, right? I can just be like, okay, what does it do for you? How do you like it? Sometimes it's just the ritual of feeling like you're doing some self-care, and so, someone might perceive that as some like nocivic, unhelpful pain thought, but I don't have to reject it. I don't have to do anything about it. I can literally just acknowledge it and keep going. I don't need them to feel, to experience any shame from me about it. It's not, it ties them to things that are important to them. It doesn't have to have some physiologic response for it to be valuable for the individual, and I think we really get stuck sometimes as practitioners, like, I don't know why you're doing that. That won't work. And it's like, well, it might not be about that.
So actually, so you said so much where it's kind of going right to one of the later questions that came in, so I'm going to see if I can frame this up well. So we have these people going through healthcare with chronic persistent pain issues, and they're kind of told like, hey, this pill will fix it. And we know one of those pills very often is opioids. And we also know that opioids are not very good for chronic pain. And that there's certainly a very large push, kind of like the orange alcohol, is that it's like, well, it's not working. We need to get you off of it. And, and kind of taking away things that even if it's not really helping like you'd hope, that people have found some sort of comfort in. And so then we start thinking about like that iatrogenic harm and kind of that feeling of like, okay, but like there's this care that I need and now I'm not getting it. So kind of this denial of care. How might you connect or explain or relate to someone who's feeling that the people in power, the doctors, anyone else, is taking away those opioids or whatever that medication is that they still want, regardless of the amount of help it's giving?
So it's funny. I don't know that I've absolutely chronic pain worldwide. That's a huge thing. I don't see it maybe because my pain doctor will prescribe opioids. So he's not. So I think my patients have it if they need it, but it certainly has. I have had patients that have had that experience and really, it's obviously their desperation for care and the denial of care, but it really stems from this deep sense of injustice that I am worthy of care and I didn't get care. Like I'm worth saving. Why aren't you saving me? And part of why we asked about the shame and stigma talk is I talk about some evolutionary principles that I think connect really deeply to patients in pain and marginalized communities in the sense that there's this reciprocal altruism that I provide care for you and Once well, then I then continue to contribute to the group, and that helps group survival. And so this denial of treatment, right, or this deep injustice when I wasn't believed when I went to the ER, or, some of these, feeling like a practitioner scoffed at my complaints, are these deeply seated injustices that make us, obviously it's very upsetting, but it really is about this evolutionary disconnection. Like, I'm being excommunicated from society, right? If nobody believes me and my experience, then how are they ever going to deem me worthy of care, right? And so we kind of get into like these deep evolutionary, psychobiologic mechanisms within ourselves about like, desperately wanting to be cared for and wanting relief, not just because it feels terrible, but because we don't want to feel like we're excommunicated from the group, right? So those things tie in a lot. And, whenever people come to me having had a really terrible experience with a healthcare practitioner in their past, I apologize. I am so sorry you experienced that. That wasn't fair. I don't have to say anything deeper than that. I don't have to make it a rejection of the practitioner. I don't have to rationalize it or explain it. They've already lived it. I don't need to be like, well, maybe they meant this. That's not helpful. And I think it's our instinct to want to try to defend another practitioner. And, I'm not saying I've never done it, but I also want to deeply acknowledge, I am so sorry that you felt that injustice. Nobody should feel that way, right? That is not a fair feeling. I am sorry you experienced that. I'm not in that person's head. I can't know what they meant by that. Sometimes I say this in this situation. I don't know if that's what this was, right? Take it or not. But I have to acknowledge their experience they bring to me, right? What is culturally significant to them? What is socially significant to them? What connects them to their communities? And I have to work within that and maneuver with it and around it while acknowledging whatever that experience was they've brought forward.
So you mentioned a lot like this kind of, right? So acknowledging that the cultural, the social, you didn't really mention it, but I know like economically, like there's like, it's not just say persistent pain that's making these people feel marginalized or be marginalized. It's usually a lot of things. And making that connection, especially when most practitioners, if they've been through grad school and all this, they don't have a similar background to connect to. And depending on where you end up working in the world, you're going to not necessarily have that understanding of the social, the cultural. So how do you make that connection with people who have such a different background or such a different lived experience than maybe you have? So how do you do that? And maybe if you can share maybe like a time where you kind of screwed it up, and if you ever have, I certainly have. But like how do you kind of bring that back together? When it doesn't go as planned.
Yeah. Well, I always stay humble and I always stay curious. And I really make sure that I don't pretend, I don't give the impression that I somehow know where they're coming from. If it's not an experience I haven't lived myself, I can say, I hear you, or I'm one of the things that emerges, especially with patient populations with low socioeconomics, is they're not necessarily going to be forthright about like, hey, I have food scarcity, or hey, they're about to turn my electricity off, or right. And so that comes with me knowing to ask the questions when I see some of the signs come up, right? Someone misses a couple of therapy sessions, I give them a call and they're like, yeah, I had to run and take care of business because they were going to, turn off my power or whatever. And then I can say, hey, the city has programs for that. Let me look up the phone number for you real quick. Or, that's a really big deal. I'm so glad, obviously that's really important. Would it be helpful if we canceled the next couple of sessions to give you time to get this back on track? Just acknowledging that there's things that might be far more important than my therapy session, and giving them that space. I love learning about people and their cultures and early in my time at my hospital, when I was an inpatient rehab on the stroke unit, the brain injury unit, the spinal cord unit, and on the stroke unit, you have a generally older population compared to maybe the BI and spinal cord unit. And I would always ask them how they cook their greens. And I would practice cooking greens at home, and then we'd compare, and then I'd like bring them in for my patient to taste. And then they could tell me how to, I brought it to some potlucks, and, to use ham hock or smoked wings or, turkey wings, but I just a deep curiosity and learning and, elders, part of our, annual learning we have to do is, different populations. And in geriatrics, they talk about generativity, right? Imparting wisdom. And, and elders love sharing their life's wisdom, and I love hearing it, right? And they love that they have that opportunity to do that. And can I incorporate that into their care in some way, right? That's even better. But really working hard to see the person and their experiences. Certainly there's times it hasn't gone well. This is funny. It's a funny story. It was a patient. It was a patient who was a little confused, and she was and it was a Saturday coverage patient. It was just, like a random holiday Saturday. I'm in outpatient therapy now, so I was up in inpatient for a random Saturday. And I was trying to get her to do some seated marches and some kicks, and she's kind of just like flinging her leg around. And I'm like, slow down. Let's like kick and hold it for a few. And she wasn't doing it. And I was like, let's kick and hold it for like 2 Mississippi, right? And she was a little confused. And then very clearly to me, she goes, "Little girl, what you know about Mississippi?" I was like, hard check. And Angie, one of the therapy aides, about fell off the mat next to us. She was laughing so hard, but I clearly reached deep into her brain and spoke about something I know nothing about. And I said, "I know nothing about Mississippi." You are correct. My apologies. I do want you to hold this exercise a little longer, and it was really, I clearly hit something, but I have to acknowledge where people are and not push my agenda on what their care needs are, and in this age of insurance, we all feel limited with time and pressure to get everything done. And we just have to not worry. If I don't get to everything, I don't get to everything. I put it in my plan to address next time. I tell the patient, I really want to hear about, X, Y, or Z narrative that you started talking about that we don't have a ton of time today to talk about, but I'm putting it in the plan. So it's the first thing I bring up when we see each other again. So they know I'm extremely deliberate about that recognition of their story and how important it is, and how anything I do, I'm trying to connect to who they are as a human. But yeah, to Mississippi.
As long as you know something about Mississippi. If not,
I was like, I know how to spell it. I know it's a river. I could name some towns in it. You are right.
So this is what happens every time I get to hang out with Devra, is that the time flies by. So this was marked for about 30 minutes, just so we can allow some time for question and answer. So here you have Dr. Devra Sheldon, only because I don't know if I'll do it cleverly at the end. I'd like to actually share Devra's contact information now. If you're like, I want more, because you'll probably want more. You can find her on Twitter at DevraJoy PT. You can also find her on Instagram, even though she admits she's not on there as much as she should be. I feel like I'm the same way. Like I should be on Instagram more, but it's just, I don't know. I'm more of a Twitter girl. I don't know.
I'm working on it.
Or you can check out her website, which is DevraJoy.com. So you can definitely find out more. But I think we should make good use of this time and click the raise your hand button function. So down reaction. Excellent, Christopher. Thank you. I'm going to, Christopher, if you'd like to, you're welcome to turn on your video, but if you'd like to ask your question out loud, we'll have Devra take a stab at it.
Sure. I had a meeting earlier with Devra, so she knows that I'm like all blanketed up. So I'll like kind of get myself in order here. Okay. So, hey everybody. Hi again. Devra. Hi, Sarah.
Long time.
So, my question, I'm going to lower my hand here. My question is, could you talk a little bit about instances or so I don't have this problem now as much in my practice, but I have had it in the past where I have a difficulty understanding what people are saying, either because of accents, dialect, or idiom. And I also don't hear super well, but that's not the issue. I hear what people are saying and I just don't understand it. And repeated, you need people to repeat themselves a lot of times, things like that. Can you talk a bit about that and perhaps ways that you've handled if you are having a hard time understanding what somebody's saying, ways to not have it become something where it seems to be being generated by you not caring what they're saying? Because I've had instances where I'm trying really hard to understand what somebody's saying and it's not working. And I feel like it's becoming a space between me and a patient.
Yeah, that's a great question. I have a lot of patients who English is not their first language, or maybe they've been here a long time and they feel like their English is sufficient for the medical encounter, but clearly as we're conversing, we need something more deep. Wherever you work, there should be access to an interpreter. So if the patient's native language might be more comfortable for them, then I definitely would pull in an interpreter. And I have patients who part of their identity is their pride and their mastery of, Americanized English. And I don't want to offend them necessarily if they feel like their English is stupendous and they don't feel they need an interpreter like this, there's obviously no deficit in it, but that's part of their identity. Maybe we start out that way. And I'll just say to them, listen, I want to make sure that I'm understanding you well. And I don't want that to be a barrier. So if I'm able to pull in an interpreter, where I am, we have access to a phone interpreter, video interpreter, and live interpreter for Spanish, Polish, Russian, and American Sign Language. So there's that. A lot of patients sometimes come with family members. And sometimes the family member might interpret a little bit, be a cultural broker. Certainly the interpreters are cultural brokers. One of my favorite Polish idioms is "not my monkey, not my circus." I learned that from a patient. That was years ago. The Polish interpreter started cracking up, and I was like, "What?" She's like, "Well, this is what he said, and this is what it means, right?" And really relying on other ways of learning what, cultural things might be at play. We years ago, we had a therapist who was French, and we had a Haitian patient who spoke like a French Creole kind of, maybe not French Creole, but it was like a Haitian French. And we have had French Creole patients. And like the patients who are like, this particular therapist was literally born and raised in France. But we also have therapists who are like, I speak French. And then they're like, yep, I don't speak that French. And you can, through the phone interpreter, I think you can actually pick some dialects, and some interpreters will understand. Like our Spanish interpreter understands colloquialisms from, Central America, South America, and she now, she can pick up on those things because they might be words that she didn't grow up with, right? Maybe, so I definitely try to work with the tools that I have, and interpreters are big, but also just acknowledging to the patient this is, I'm struggling with this. It's not you, it's me, right? You're fine. I'm going to figure this out so that we can communicate better.
Thank you.
You're welcome.
I love that. Thank you, Devra. Okay, next up, Melissa Farmer.
Hi, thank you. I've loved your talk so far. I'm really curious about sociocultural differences in how people describe pain and their pain experiences. So this could be metaphors, but how do you get at that whenever sometimes people aren't used to describing pain in the level of nuance that I'd prefer or I'd like. So how do you deal with that?
That's a great question. It happens a lot, right? Most of my patients are not like me, right? Do not come from my background and experiences. And they're really just accustomed to giving a pain rating, right? So I'm asking, how would you describe it? They're like, what do you mean it hurts? Like, I already described it for you, right? And then I'll, is it achy? Is it dull? Is it sharp? Is it shooting? Is it tingly? Does it feel detached, right? And then they, that can help. Something that actually the Spanish interpreter I work with and I talk about a lot is that I would say older Hispanic populations often I've experienced that they might become really tangential when you ask some of these questions, like, how do you describe your pain? And they're like, well, I try resting it and rubbing lotion on it. And, and I move it like this. And it's like, yep, nope, not even close to what I asked, And so that sometimes when there's, language barriers, that is their cultural norm of how they would answer that question. Also, they clearly want me to believe that they're trying and doing things. Right. And so there are times that in this particular example with this individual, I just asked the interpreter, right? Because normally an interpreter is literally just going to say verbatim, right? What it is you've said, but maybe the way I've framed it isn't the best way for that person to receive it. And so I'll ask, the interpreter, is there a better way to ask this question about how would they describe the pain? The other thing I do sometimes is I acknowledge, I know this question, might seem weird and no one's ever asked you this question before, right? Recognizing that I'm asking them to reflect in a way that's different, that's weird, that feels not typical. And just kind of putting it out there, like, I fully know that this is not anything you've maybe been asked before, but take some time, think about it, think about later if you want to come back and you have some other thought about it. But that's how I try to approach it.
All right, thank you. And it's perfect. We have time for one more question and we have one more hand raised. Mike, it is your turn.
Perfect, thank you. I guess my question was just focused on patients that have significant visual deficits, complex patients that may be legally blind or have severe conditions. I know one patient I'm treating has glaucoma and macular degeneration. Have you been able to, do you have experiences managing pain with those populations? And how did you go about that? Did you find any resources to help you?
Well, there is, I definitely see patients who have significant visual impairments. Also, I work, in brain injury. So that's a real, in stroke, they could have lots of visual stuff. Do you feel like the visual impairments are exacerbating the pain experience?
Slightly, yes.
Was the visual impairments related to some precipitating injury that also precipitated their pain?
In the one of the cases that happened because it was like a worker's like an explosion at a site. That's when they lost their vision. It was newly blind. So that in that case, yes.
Things like I mentioned it a little bit earlier, themes of injustice. The articles that I included as references in the Shame and Stigma talk on injustice actually specifically talk about work-related injuries.
Gotcha.
It's really, and I have patients, this was earlier last year, a patient I shared with another clinician. I said to her, literally every session, he brings up this injustice related to, his care after a traumatic event. And I was doing this talk, I was preparing for this talk, and I'm like, it's these really strong themes of injustice. And so, the visual impairment can be a reminder of that injustice, of feeling like a employer or work site wasn't taking necessary safety precautions, and the workers' comp process is awful. It's really miserable. And it's never a nice experience to go through for people. So sometimes it's like, is that impairment, related to, whatever the precipitating thing was that led to pain, and sometimes it's about me connecting them with resources. Right here where I am in Chicago, it's the Lighthouse. We also have occupational therapists who have, extra, OTs will do visual stuff anyway, but some have even, more additional visual training. And I've also had to train people on blind cane use for street crossing. And actually just had a patient this summer with a brain injury who had cortical blindness related to his brain injury, that we dealt with a lot of visual stuff. You can pull in, one of the things that people really approach us for is they want to reconnect with who they are and their identity and their former self. And, it's like, I just want to be me again. And sometimes it's, can I be flexible and creative in how I can help them harness those things that were really relevant to them in light of their impairments to help them feel more connected to their former self. The example that comes to mind is I've had several patients who prior to their pain used to love to do Zumba or dance bachata or something like that. And I will literally do it during our therapy session, right? I'll pull up YouTube and we'll be in the gym at our mat table and there will be no shame in our game. And even if it's, even if it hurts, even if they're not great at it, it really can bring an element of joy to them that is really valuable, even though it's not, doing 5 sit-to stands, which brings me a lot of joy when I do 5 sit-to stands. So,
Absolutely. Thank you.
I love it. Oh, Rajam said that there's places that have like ballroom dancing for visually impaired. There's a lot of really cool resources out there for visual impaired. As I said, the organization closest to where I am is the Lighthouse, and it's, we refer people there. And it gives them community. There's classes to learn how to read Braille and type. They do movies with, augmented audio, sound and stuff. It's cool.
All righty. Any other last minute questions before I wrap up for the evening? Oh, we got one more. Joanne, go ahead and ask your question.
Yes, hi.
Hi.
My question was, how did you get to where you are now?
Oh, wow. So my mom's an occupational therapist and has chronic pain. So that definitely colored my childhood. She had chronic low back pain as a teen and was specifically told not to become a physical therapist because she wouldn't be able to handle all the lifting, right? Some nice CBIC messages in the 1960s. And so she became an occupational therapist, and, growing up that, OTs are all about self-efficacy and, modifications and stuff. So she was living, she was always working on strategies for self-management, even if she didn't call it that. And then when I was a freshman in college, actually, she was working in a pain program and tweaked her knee with the patient, ultimately had a knee scope, had a second knee scope, and then ended up with raging CRPS. So, while I'm in PT school, right, and this is when they called it RSD and they didn't recognize it right away and, things like that. So I always, even though I really went the neuro track and I'm board certified in neurology and I love, working in stroke and brain injury and spinal cord injury, I always had this parallel life in pain. And I always, kind of read stuff on the side, even if I, wasn't seeing that patient in front of me. And I've been at my hospital for over 15 years now. I deeply love working with my patient population and helping them feel cared for, that a practitioner takes the time to listen and incorporates that and remembers that and acknowledges that. And that's the short version.
Okay. All right. Well, thank you so much. So that's about all the time that we have. I think that Rajam is going to come back on and say something in closing. Or I can wrap it up.
No, I can. Sorry, I was like, what? I have to say something in closing.
No, you don't have to. I was going to give a plug for the San Diego Pain Summit, but I didn't know if you wanted to.
No, I just thank you guys for attending this little free short talk. Feel free to email me at info@sanDiegoPainSummit.com if you have any thoughts about it or you would like to see more of a particular subject. I'm always looking for new things to bring up at the summit. And yes, you can go to SanDiegoPainSummit.com and find out about the 2022 event. But thank you guys so much for attending and participating. And we'll see you later at another talk, hopefully.
All right. Thanks for showing up, guys. And Rajam, thanks for hosting this.
Sure.
Definitely. And hopefully see everyone in February in San Diego.
I'm signed up. I will be there.
I will be there with Ali. I'll have a little helper.
I love it. I can't wait.
Awesome. Steven's going to be there.
Thank you.
Okay.